Good morning. My name is Dr. Peter Rowland, and today we're going to talk about candidacy guidelines for both sound bridge and bone bridge. That is, we're going to talk about what types of patients are appropriate both for the sound bridge and for the bone bridge. And although the candidacy guidelines overlap, they are not the same. If you look at the slide, you can see that there's a red bar across the top that has bone bridge written in it, and below at the bottom of the slide, you can see that there's a red bar that has sound bridge written across the bar. And these indicate which patients are candidates for the different devices. So you can see that for conductive hearing loss, and particularly atresia cases, both the bone bridge and the sound bridge are potential choices for individuals with this particular medical problem. Similarly with mixed hearing loss, that is hearing loss where there's difficulty in the ossicular chain or in the external auditory canal, and in addition to that sensorineural hearing loss, those individuals too can be managed either with bone bridge or sound bridge. However, note that single-sided deafness is only appropriate for the bone bridge, or the bone bridge is only appropriate for single-sided deafness, and the vibrant sound bridge is not a useful solution to individuals who are deaf in one ear and have relatively normal hearing in the other ear. So let's talk first a little bit about conductive hearing loss, and today we're going to focus particularly on aural atresia, that is, absence of the external auditory canal and abnormalities of the ossicles with a significant conductive hearing loss. And this includes patients with both unilateral and bilateral aural atresia, that is absence of the ear canal, individuals with unilateral and bilateral macrotia, that is abnormally small and usually deformed external ears, and individuals who have both unilateral and bilateral complete absence of the external ear. And you can see here a typical audiogram from one such individual with a near maximal conductive hearing loss of between 40 and 50 decibels, and the typical malformation you see with many types of aural atresia. So the traditional treatment options for conductive hearing loss are reconstruction of the external auditory canal, sometimes with associated ossiculoplasty. In some parts of the world, this has been largely abandoned because it's not a terribly effective remedy, either for the cosmetic deficit or for restoration of hearing. Middle ear implants are useful in managing this type of deformity, and bone conduction hearing devices are also appropriate treatment for individuals with a conductive hearing loss due to atresia or absence of the external auditory canal. So the indication criteria are basically similar for bone bridge and sound bridge. Subject needs to be 5 years of age or older. They need to have bone conduction thresholds within the respected shaded areas, and I will show you those shaded areas in the next slide. The anatomy has to be appropriate for placement of the device, and we'll talk a little bit about that. And they have to have absence of retrocochlear or central auditory disorders. For instance, an acoustic neuroma patient would not be appropriate. And they have to have adequate motivation and realistic expectations for what they can expect in the terms of results from the device. Here you can see the shaded indication criteria. So this is a pretty important slide, one worth focusing on. And for bone bridge, please note that the bone conduction has to be within this red square, which means that between the frequencies of 500 and 4,000 cycles per second, the bone conduction threshold needs to be no worse than 45 decibels. Additionally, to get really effective outcomes from bone bridge, it is advisable that the air-bone gap be at least 30 decibels. For sound bridge, you have a little more latitude in terms of bone conduction. That is to say, in these highest frequencies, the bone conduction can go as low as 65 decibels. So, bone bridge is relatively ideal for children and adults with severe malformations of the inner ear, that is, individuals whose anatomy would make it difficult or impossible to implant a vibrant sound bridge. A good example of that is where the stapes is fixed or absent or not robust, and we'll talk a little bit more about that as well. The sound bridge is ideal for children and adults with malformation of the ear if the stapes is intact, mobile, and robust, and it's useful in individuals whose air bone gap is less than 30 decibels. So, users benefit from management of conductive hearing loss using an implant because the outer and middle ear are bypassed. There's an intact skin solution, that is, with either sound bridge or bone bridge, there's no post coming through the skin. Because the vibratory impulses are generated by the implanted portion of the device, there doesn't need to be a lot of pressure from the speech processor onto the skin, and yet reconstruction of the external auditory canal, or pinna, is still possible. When you use the vibrant sound bridge, you have the additional advantage of developing the ability to localize sound, that is, tell what directions sound are coming in. So let's move on from atresia cases to mixed hearing loss. Typical examples of such patients are individuals who've had cholesteatoma surgery or surgery for severe recurrent infections and either have missing ossicles or the ossicles have become damaged or fixed as a result of the disease or the operation, and in addition to that, have significant amounts of sensorineural hearing loss. So both bone bridge and sound bridge can potentially be used in these individuals. The pathologies that are typically associated with mixed hearing loss are cholesteatoma and cholesteatoma surgery, chronic inflammation of the middle ear, and previous middle ear surgery of almost any type. And you can see here a typical audiogram of a mixed hearing loss. This is a typical audiogram for an individual who's had cholesteatoma surgery, where one or more of the ossicles is removed. And they have sensorineural loss down to about 40 decibels. But on top of that, they have a conductive hearing loss of 30 decibels. And here you can see a picture of a small cholesteatoma. This one is small enough it's not likely to have produced much of a mixed hearing loss, but it will eventually. A large tympanic perforation, possibly with atelectatic drum on the promontory, and a severely diseased external auditory canal. So treatment options for mixed hearing loss include reconstruction plus a hearing aid, so that traditionally these individuals have been managed with a TORP or PORP or some ossicular replacement prosthesis, and then additionally provided with a hearing aid to overcome the neurosensory component. They can be treated with a middle ear implant, like a vibrant sound bridge, or they can be appropriately treated with a bone conduction device. So the indication criteria are essentially the same for this indication as for atresia. They need to be 5 years old or older. They have to have bone conduction within the respected shaded areas. The anatomy has to be appropriate so that you can actually put the device in effectively, and they have to lack retrocochlear or central auditory findings, and they must have adequate motivation and expectations. So here again you can see typical examples of mixed hearing loss. Here you can see a good candidate for bone bridge. The bone conduction is clearly within the shaded area, but they have a superimposed conductive hearing loss. And it should be noted that the conductive hearing loss can be of almost any degree, so that if the air conduction level was down here, that would also be okay. Here you can see a sound bridge candidate where their bone conduction is a little bit worse. That is, they have a more severe sensorineural component. But in addition to that sensorineural component, they have an associated air bone gap. So bone bridge is good for individuals who have relatively mild sensory neural components, for individuals where the stapes is not intact, nor mobile, nor robust, and who have an air-bone gap of at least 30 decibels. Sound bridge, on the other hand, is ideal for individuals who have moderate inner ear hearing loss, a moderate sensory neural component. If the stapes is intact, if it's mobile and it's robust, and they can have an air-bone gap of less than 30 decibels and still do well with the sound bridge device. So individuals with mixed hearing loss benefit from these devices, again, because the outer and middle ear are bypassed. So if you have a patient with middle ear or external canal pathology, you can safely radically eradicate that pathology and still have the ability to restore their hearing. The hearing benefits you get are stable in the sense that if subsequently there's negative pressure in the middle ear and retraction of the eardrum, it doesn't matter. They will continue to be able to hear well. It's an intact skin solution. Again, low pressure through the skin from the audio processor, and pinna reconstruction is possible. And as before, localization is possible if you use the vibrant sound bridge. Single-sided deafness is a pathology that is not appropriate for the vibrant sound bridge, but it is appropriately managed with a bone bridge. And here's a typical example of an individual with essentially a total absence of hearing, total deafness in their right ear, but relatively normal hearing in the left. And as all of you know, common causes of sudden deafness include sudden neurosensory hearing loss, congenital conditions where the individual is born with unilateral hearing loss, from retrocochlear lesions like acoustic tumors, and individuals with cochlear ossification, usually as a consequence of meningitis. The challenges that patients experience with unilateral hearing loss include difficulties hearing in noise, difficulty understanding speech, especially when it comes from the side of the deafened ear, limited ability to distinguish between different sound sources, inability to tell which direction a sound is coming from, and they lack the summation effect of, that you get when you hear binaurally, so their ability to understand what's being said is worse than normal. So traditional treatment options for sudden sensory neural deafness include direct stimulation of the deaf ear using a cochlear implant. And as you know, this is a relatively new indication for cochlear implants, but is becoming increasingly popular because it actually stimulates the deafened ear. Traditionally, cross hearing aids have been utilized, usually with not a high level of satisfaction from patients, and it simply takes the sound presented to the deaf ear and presents it to the contralateral normal hearing ear. Another way to essentially accomplish the same thing is with a bone conduction implant. It also takes the sound from the deaf side and delivers it to the normal hearing side, but it does it by routing the auditory signal through the bone of the patient's skull. So the indications for bone bridge are, again, 5 years and older, single-sided sensory neural deafness, and please note that the air conduction levels have to be pretty good in the contralateral ear. In fact, basically normal with thresholds greater than 20 decibels. The anatomy has to allow for appropriate placement of the bone bridge, and they should have adequate motivation and expectations. Users benefit from bone bridge and other bone conduction implants because the head shadow effect is alleviated, that is, the sound delivered to the deaf side is presented to the normal hearing side, so they will be able to hear it. They have improved understanding in noise, especially when the signal they're trying to listen to comes toward the deafened ear, and it makes everyday living easier. They have to struggle less in order to function effectively in their everyday environment. And so that concludes this relatively brief discussion of indications for both sound bridge and for bone bridge. Thank you very much.